Good morning, everyone. I'm thrilled to open this symposium, which will focus on the next generation in patient care, part of the controversies in ophthalmology meeting, of the COPHy meeting here in Seville of 2025. This is a Bayer-sponsored symposium. So first of all, I would like to welcome all of you to the Bayer-sponsored symposium here in Seville in the year of 2025. I would like to start with some housekeeping notes. No recording is allowed in this. Oh, you don't see the slides. Slides? Yeah. No recording is allowed in this symposium. You will have poll questions, but you will answer them by just the very low-tech technique of raising your hand when prompted. And please take a few minutes at the end of the symposium to fill the feedback survey by using the QR code to access the brief anonymous survey so that we know how to improve for the next time. I'm very fortunate to be joined by my excellent, very good friends and colleagues, Professor Paolo Lancetta from the University of Udine in Italy, Professor David Brown from the Retina Consultants of Texas in the United States, and Professor Patricia Uduando from La Fe University and Polytechnic Hospital here in Spain. Thank you very much for joining me for this symposium. The symposium's aim is to focus on how aflibercept 8 milligram provides better, faster, and longer drying with extended treatment interval for our patients with retinal disease. It will highlight the applicability of aflibercept 8 milligram for all eligible treatment-naive patients, including the way it's used in clinical practice. We will also elaborate on how the 8 milligram will have the potential to actually shape the future clinical practice. Following this very brief introduction, I will tell you a little bit about the latest with aflibercept 8 milligram. This will be followed by a talk by Professor Lancetta on the question if aflibercept 8 milligram provides better drying, where better drying is needed. Professor David Brown will talk about aflibercept 8 milligram in treatment-naive patients, a very important question. And Professor Patricia Uduando will talk about the future clinical practice. At the end, we'll have some expert perspective during a panel discussion. So let's focus a little bit on what's the latest about the aflibercept 8 milligram. So the very good news, the aflibercept 8 milligram prefilled syringe has been approved in Europe in September of 2024. And it is excellent technology. It provides actually what we hoped for, the next generation precision, simplicity, and efficiency. It has simplified priming with no filter needed, streamlining the injection process to a very easy process. Also, it has an innovative preset mechanical dose setting with the setting designed to deliver exactly the needed dose of 70 microliters of the aflibercept 8 milligram, and we know that it is a big issue, providing control, stability, and comfort with a very ergonomic design. This way, we can know that the patients are really getting the precise amount as needed, and we know from previous studies that also we did that not always the amount given is the amount that we want to give. And in terms of sustainability, there is 40% less packaging versus the 2 milligram prefilled syringe, which is also important. So this is one news that I wanted to share with you. The other one is talking about the PULSAR extension study for 3 years. PULSAR was a study that evaluated the efficacy and safety profile of aflibercept 8 milligram in patients with AMD. And now this talks about the results through year 3, including the group who was switched for 2 milligram to 8 milligram with a longer extension. So after the completion of the PULSAR trial, patient could join the PULSAR extension, which is open label and optional. Patients on the 8 milligram both Q12 and Q16 were continued according to their last assigned interval, and patients on the 2 milligram were switched to the 8 milligram Q12. And it's nice to see that the vision gains were sustained with as 2 injections in the 3rd year. This is, I think, excellent results that really shows that the 8 milligram provides a longer duration. Also, when we are talking about drying, the central retinal thickness reduction were also sustained with as few as these 2 injections over the last year. 4 in 10 patients randomized to 8 Q16 at baseline had the last assigned treatment interval of more than 5 months or more. Really, really a very long interval. And what is really important to us always is that the safety profile was similar and not changed, and no safety concerns were raised. The photon extension study assessed the efficacy and safety profile of aflibercept in patients with DME through year 3, including the ones who were switched from the 2 milligram to 8 milligrams. So again, following the completion of the photon trial, patient could be switch over to the photon extension, where the patients that had 2 milligram were switched to 8 milligram given every 12 weeks, and the patients that had 8 milligram continued 8 milligram according to their last assigned treatment interval. And again, the very meaningful vision gains were sustained over the 3rd year. The patients showed the patients switched to aflibercept 8 milligram showed longer fluid control with substantially slower fluid reaccumulation compared with the 2 milligram. 5 in 10 patients randomized to 8 milligram at baseline had the last assigned treatment interval of 5 months or more, which is a very long treatment interval. And what is always important for us is that the safety profile was maintained through the 3rd year. QUASAR is a study evaluating the efficacy and safety profile of aflibercept 8 milligram in another indication, in retinal vein occlusion. In this study, the patients are randomized in a 1-to-1-to-1 fashion to either 2 milligram given every 4 weeks, 8 milligram every 8 weeks after 3 initial monthly injections, and 8 milligram every 8 weeks after 5 initial monthly injections. The primary endpoint is at week 36, and at week 64 is the end of the study. When we look at RVO also, and it's nice to see that it's going across all indications, aflibercept 8 milligram did meet its primary endpoint of non-inferior vision gains compared with 2 milligram, but with a fewer number of injections. It demonstrated early and very robust CRT reductions through week 36, 70% after 3 initial monthly injections at the last assignment interval of Q12 weeks at week 36. And again, it was well tolerated, no new safety signals also in this group of patients that potentially could have other side effects. SPECTRUM is an ongoing global study which is conducted across 18 countries all over the world with multiple sites. You can see here the countries, both in Europe and in North America. It's going to include a robust amount of patients of 2,500, so a lot of patients, and will give us a lot of more information on the use of aflibercept 8 milligram. It will generate a lot of long-term data, and we all are seeking this long-term data from real world on both of the effectiveness and the safety profile of 8 milligram in AMD and DME. It's a prospective real-world study, and across these 18 countries, there will be 4 patient cohorts, treatment naive, previously treatment, this for AMD, and the same for DME. So we will have a lot of information from this study as well. So this was just to set the platform to the next talks, and I'm very happy to invite Professor Lancetta, who will talk about the drying effect of the 8 milligram aflibercept. Paulo?
Thank you, Anna. Thank you all. So let's move to the retinal fluid and the drying effect. You see, by using aflibercept 8 milligram, you will see some data coming from the pivotal trial, the PULSAR, and the PHOTON trial. So the question is whether aflibercept 8 milligram has a better, faster, and longer drying effect versus the standard of care, which is aflibercept, or was aflibercept 2 milligram. This is coming from the PULSAR study. There are 4 AMD patients, and this is a secondary outcome from that study. You see that the proportion of patients without retinal fluid in the central subfield at week 16 was definitely better in patients treated with the 8 milligram dosages. So there was definitely a better drying effect versus aflibercept 2 milligram, superior drying effect. And this was true either at week 16, secondary outcome, and later on at week 48. If we move to the PHOTON trial, patients with diabetic macular edema, and this is a post-hoc analysis, again, does aflibercept 8 milligram provide a better drying effect versus the 2 milligram? And you see that there is a more resilient fluid control with the higher dose versus the 2 milligram, even when you do consider eyes who have the more severe type of the disease. In fact, those patients with the higher values of central retina thickness, the 4th quartile, you see more than 528 microns were analyzed by these post-hoc analysis. And you see that the 8 milligram dosage really has less fluid reaccumulation after the loading phase. So you want to compare patients after the 3 loading doses with patients after the 5 loading doses in the aflibercept 2 milligram. And there are some significant differences when you do evaluate CRT in the 2 milligram. After the loading phase, the increase in CRT was 55 microns, whereas it was quite negligible in the 8 milligram dosages. So a more durable treatment effect with the 8 milligram versus the aflibercept 2 milligram in patients with diabetic macular edema. Again, in terms of better drying in the extension phase, so the 3rd year for patients with diabetic macular edema, you see here the proportion of patients without fluid in the foveal center. You see the aflibercept 2 milligram patients during the 1st year. At week 48, 53% of those patients didn't have fluid in the foveal center. We move now in entering the extension period, the 3rd year. Week 96, patients were still in the 2 milligram and were treated with the higher dose exactly at week 96. So 76% is the longer follow-up of patients still being treated with the 2 milligram. Then they enter the treatment with the 8 milligram, and you see some more improvement in terms of patients without the fluid, moving from 53 and 76 to 86, 83, and 83% with no fluid in the foveal center at week 156. Again, from the PHOTON post-hoc analysis, better drying, you see greater CRT reduction with the higher dose compared to the 2 milligram in patients, again, who do require more frequent dosing. You see on the left side, patients who need additional injections. So they met the shortening criteria versus those patients who didn't met the shortening criteria. And you see the evaluation at week 12, and clearly the evaluation is in favor when you do consider the mean CRT changes of patients receiving the 8 milligram versus the 2 milligram. Going back to the PULSAR study, AMD patients, in terms of faster driving, we are now quite used to this type of slide, and there is a faster time to fluid-free status with the higher dose. You see here the median time to a fluid-free central subfield was 8 weeks for the 2 milligram versus the 4 weeks independently from being enrolled in a Q12 or a Q16 arm for the 8 milligram. Again, back to the DME patients in terms of rapidity of drying, there was, again, a faster COT reduction in patients with the higher dose. And here is the cumulative risk for the time to getting a CRT of less than 300 microns, basically edema-free through week 48. And you see the median time for reaching this beneficial condition was about 28 weeks with aflibercept 2 milligram, whereas it was very, very early, just after the first single injections in patients treated with 8 milligram 4 weeks. Longer drying, so moving to durability of these higher dosage, the 8 milligram, and we are back to the PULSAR with the whole follow-up throughout the extension phase, 156 weeks. We do see the mean change in central retinal thickness from baseline, and you see that the outcomes are very inspiring in both patients treated from the very beginning with the 8 milligram and patients who are later on transition to the higher dose coming from the standard of care 2 milligram. And you see that this has been obtained with only 12.7 injections on average for the 8 milligram patients. And this could also, in a subgroup of patients, be obtained with as few as 2 injections in the 3rd year, and this is very notable. Back to the photon, still in the extension, better and longer drying. And you see here again the mean change in central retinal thickness from baseline. You see patients coming from the 2 milligram treatment, and remember at week 96 they were immediately treated with the 8 milligram dosage, and you see that following the single injection with 8 milligram there was a reduction of 54 microns, which was much better than anything obtained during the first 2 years with a 2 milligram. And if you continue following the patients, you see that compared with the first 2 years of treatment with aflibercept 2 milligram, fluid reaccumulation after that injection was lower 8 weeks after the first dose of aflibercept 8 milligram. So just to remind you, patients transition from 2 milligram to 8 milligram had these 8 milligram injections at week 96, and then they enter a Q12 regimen. And this is also very notable. I don't see any slide here, but I can go on with the screen. And you see the subsequent follow-up, which is also quite interesting because when you move the patients to the higher dose, you have some further improvement in the decrease of CRT, minus 197 versus minus 169 at the end of the 2-year treatment with the lower dose. We want to extend treatment intervals. This is the unmet need, or has been the unmet need for years now. So let's give a look to how we can extend treatment intervals, and this is true for both the PULSAR and photon. You see here the extension, which were possible only starting from year 2 on, and you see different criteria for the PULSAR and the photon. Remember, the intervals could be shortened both in year 2, but extended only starting from year 2. So you see the mean number of injections from baseline to week 96, just focus on the 8 milligram groups, 8.9 in the PULSAR trial, 8.9 again in the photon trial. And if you pick up patients who were originally assigned to Q16 interval time, that number goes down to 8 injections. Remember the time of the magic number, the so-called magic number at the time of ranibizumab or aflibercept 2 milligram. The magic number was the average number of injections to have some improvement and maintenance of visual acuity improvement during the first 12 months in naive patients. That number was 8, and now 8 is spread out not on 12 months, but on 24 months. This is the extension criteria during, of course, the third year. And you see in terms of possibility to extend, let's focus on the number of treatment, 3.8 injections in the PULSAR AMD patients and 3.3 in the Photon study DME patients. And again, referring to the PULSAR, a subgroup of patients could receive only 2 injections during the extension phase. Let's translate it in last assigned treatment intervals. Back to the PULSAR, at the end of 156 weeks, 6 in 10 patients did receive an injection every 16 weeks or higher interval, and 4 in 10 patients had that injection every 20 weeks or longer intervals. And you see of note that almost 24%, independently from being originally assigned to Q12 or Q16, could reach a 6-month interval time. This is something we never saw with the standard intravitreal anti-VEGF administration. I will look at that one now. So one on the left side and some on the right side. You see in the Photon DME patients, 7 in 10 patients did reach at least this Q16 interval, and 5 in 10 patients, very similarly to the PULSAR study, reached at least Q20. Very interesting. And these early gains and meaningful vision gains were sustained in patients with neovascular AMD through year 3, as you can see here. And of interest is also that patients who were transitioned to the 8 milligram were very similar on the slope or the curve of visual acuity. Going to the Photon, very similar initial gain, and then maintenance, sustained visual acuity through year 3. Let's go to a couple of cases very rapidly. This is a patient of ours who started, naive patient who started aflibercept 8 milligram. You see the characteristics, AMD patients, CNV is there, PD, some massive fluid intraretinally, 20/63, not that bad visual acuity, fluorescein angiography, type 1 lesion. And this is 1 month after aflibercept injection. 20/40, improvement by 10 letters, the PD is gone, the fluid has completely reabsorbed. This is something we don't routinely see or we didn't see during the past years with different anti-VEGF agents. 1 month after the second injection, very stable. This is the monitoring period. 1 month after the injection number 3, 2 months after injection number 3, stable, and 3 months after the injection number 3. And this is 4 months after injection number 3, and you see the very stable situation. And this is after injection number 4, 1 month, and 2 months. This is the latest follow-up we have. And this is the summary for this patient. And this is a patient with diabetic macular edema, one of the early ones we enrolled. You see OCT at baseline, right eye being treated, fluorescein angiography, and you see injection number 1 month after, some improvement, some more improvement after the second injection. And now the patient is dry after the loading phase. This is really fascinating. This is the full course of the treatment and monitoring. And so the answer is yes, aflibercept 8 milligram provide better, faster, and longer drying effect versus aflibercept 2 milligram. I've shown some data to prove that, which are summarized there. And I think we can discuss now. Thank you very much.
ask you, as you showed, you are always an early adopter, and I know that you are using a lot of the 8 milligram, like you always are using the best treatments, the newest treatments. What do you see in your clinic in terms of drying? I mean, you showed these 2 cases, but is it as a general rule, not only extending the period, but also a better drying?
Yeah, we started early, and we are very curious whenever we're using a newer drug. So we started seeing the patient back very frequently, which means 1 day after the injection, 1 week, 2 weeks, 1 month, 2 months, 3 months, and etc. And the first patients we did enroll, they lately after the loading phase, they had a decrease in central retinal thickness by 135 microns. And very interestingly, 1 day after the injection, 32% of that improvement was obtained, which went up to 60% of reduction at 7 days, and it was 70% at 15 days. And by 30 days, after 1 single injection, it was minus 84%. And by 60 days,
is this an average
it was 90%. And it was the average in our first 30 eyes enrolled in this early effect evaluation.
So yes, you did see it in your patients.
Yeah.
Just in 1 sentence, Patricia, Paulo showed us both in the extension trials and in the trials and in his patients that there is a drying effect. Is it important to you that the retina is dry?
Yeah, I think it's very important. Fluid matters in the end, in the short and in the long term. And we also have the same feeling. Also with the change from 2 to 8, it really dries better.
Okay, thank you very much. And without further ado, let's continue with Professor Brown. Can we have the slides, please?
I think they're
Thank you very much. This part of the talk is going to be talking about why you use it on treatment-naive patients.
Clicker?
Yep.
You have the clicker? Yeah.
Financial disclosures. I did a lot of the work on designing the 8 milligram trials and getting the molecule to where it is. So why should we start treatment-eligible patients naive on the best drug we have in our armamentarium? And antibiotics, you kind of wait, right? You kind of hold off on the really big antibiotics for only the toughest cases. In our field, it's different. In our field, it's all about compliance and how many visits, and do you have the healthcare delivery system to be able to take care of the population that which you're entrusted. So a lot of you have heard me talk about a bell curve, where some patients clear drug fast and need drugs very frequently, whereas the others are, lucky and you don't see them as often. And it turns out that in our clinics, it kind of builds up those that are frequent flyers, the ones that need lots of injection because they're in the clinic more. But when you first see a patient, when they present, do any of you able to tell, is this going to be somebody who can get by with, every 8-week dosing with 2 milligram of aflibercept, or is this going to be one of our every month and they miss a day, they go, they miss a week and they recur? Or is it one that's even longer? I don't think anybody knows, right? And we've looked at, you just can't tell an initial presentation. We could probably tell with an AC tap. If you did it a week later or a month later, you could do pharmaco-PK testing like we've done in our trials. And we're working on some of that. But at this point, you don't know. So you have a patient like this nice lady. This is a 99-year-old lady from Central Texas. She still bakes cookies for her grandkids and is very productive. And now she's got trouble in her good eyes. So she's 20/60. You have some intraretinal fluid. The image on most 99-year-olds aren't great because of dry eyes and such, but you can definitely tell she's got wet AMD. So she's the perfect patient to give EYLEA HD because you know that there is an urgent need, and this is the kind of patient that it is hard to get her into the clinic. Right? She has some mobility issues. She has to have a ride. Her family basically takes off and picks her up at the nursing home and brings her. But you want to keep this lady seeing as best she can because she's a very functional 99-year-old. So aflibercept, if you haven't heard about it by now, then aflibercept molecule is a fusion protein of the two fusion of VEGF. Of note, it's a pure human protein. In other words, because it's a fusion protein, it's 100% human. It's not humanized. There are no antibodies for VEGF that are truly human, and that's why all the other things in our armamentarium are mirroring or mouse antibodies that have been converted to try to make them fool the body that they're not mouse antibodies and they've been humanized. And that's probably why we have the amazing safety profile with the aflibercept 2 milligram and 8 milligram, as opposed to the other molecules out there, that there are some obliterative vasculitis. It's rare, but sometimes you just can't fully humanize a molecule. So you block all kinds of things. The main thing's VEGF-A, but also you block placental growth factor, VEGF-B, and galectin-1. So the big thing about this molecule, or this dose that we're talking about, is it's a 70 microliter dose, which gives you 8 milligram aflibercept, which is 4 times 2 milligram aflibercept. That seems pretty self-explanatory, but the interesting thing is when we did clearance data, there's actually you get more than 2 half-lives, because the aflibercept 8 milligrams got a 34% slower clearance. We don't think it's due to the formulation. It may just be that the pathways of clearance of drug out of the eye get over, you have so much drug in the eye, it takes longer to clear. It'd be like a motorway where you have a smaller lane going out. You basically, impede the ability for the drug to clear. So 8 milligram aflibercept's estimated to last, in some patients, 6 weeks longer than 2 milligrams of aflibercept. And here's just an animation. So here's my lady, and we give her 1 dose, and she has a nice response. Her visual acuity really hadn't changed, but she's not noticing the metamorphopsia. The fluid's all gone. We give her another dose. She's absolutely dry, and in the United States, a lot of times we will extend before the 3 loading doses. The label in Europe is 3 loading doses before extension, but in the US, we often don't do that. Here, this lady, I went straight to 12 weeks, warning her if she notices anything to come in early. And here at 12 weeks, fortunately, there's no recurrent fluid, so we're dosing her at 12 and planning on extending her out 14-ish. I don't want to go too long because this is their only eye, and you can keep testing the interval. But especially in monocular patients, I'm very happy with a 3-month-ish or a little bit longer follow-up. Especially in diabetics, I'm more concerned if you extend some of those patients out 4 months or longer, they don't come back because they think they're cured because they got there by 15 years of non-compliance with the medical regimen. So you want to make sure that you've got some control over them coming back. So here we shifted the curve. So what about clear choice for treatment naive? There's a lot of reasons. If you look at all our baseline characteristics, there's no ones that it really doesn't work in, and there's none that didn't extend more with 8 milligram than 2 milligram. Just going to go over those briefly. Baseline visual acuity, no matter whether they had good or bad baseline visual acuity, here you see that in almost every category across the board, the green is more than the blue, showing you that 8 milligram of aflibercept allowed good control even with less frequent dosing. Same thing on central retinal thickness with neovascular AMD. The ones with lots of fluid, which oftentimes are more classic lesions, and I'm going to show you lesion type here as well. Again, good visual acuity gains with less frequent dosing. Here you have, thank God we don't have to do fluoresceins and talk about and draw the classic and occult like we did with PDT. Most in the room are not even old enough to remember that, thank God. But it works across all lesion types. Here you have baseline visual acuity. again, it's really all comers. You get equally effective treatments with longer dosing intervals. Baseline CRT, just showing you that everything we looked at, age, race. Here you see a little bit more extensions in the Asian population. This may be that polypoidal just is more sensitive, and it may just be the population. Again, everything we studied, 8 milligram gives you effective control with less frequent dosing. Here you see the visual acuity curves. The prior treated DME, that's a tougher population. You don't go in a trial if you're well treated with DME, and so it's a tougher population. In this population, it looks like most of them did need Q12 as opposed to Q16. But with Q12, they got excellent control, and none of those in clinical practice do well on Q12 dosing with 2 milligram of aflibercept. Here's a CRT change, again, very effective drying agent. It's 4 times the dose, so it's much more anti-VEGF blockade. It's actually, the competitor Vabysmo is about 65% of the power of 8 milligram of aflibercept dose. So you're basically using almost a dose and a half of Vabysmo anti-VEGF blockade. And most of us feel that the anti-VEGF is the majority of what makes these drugs work. Extended intervals, we've shown you this with Palos. We get patients extending way longer than we ever have with any of our previous drugs. So again, everything that comes forward, there's no reason on a treatment-naive patient, whether it's baseline visual acuity, CRT, CNV type, or race, that would steer you away. Lastly, I'm going to show you what the patients that really want this drug, the patients that are not treatment naive, the ones that are having trouble. This is a lady with 88-year-old gentleman, OCT at baseline, big PED, subretinal fluid. He's pretty well controlled on aflibercept 2 milligram, but literally can't go more than 5 or 6 weeks and he gets recurrent fluid. They all see the TV ads in the United States and want to know why they can't go as long as the people in the TV. I always tell them it works better on TV than it does in real life, but here you have faricimab, so we switched to faricimab, and they actually don't do any better on faricimab than they did on 2 milligram of aflibercept. They can get 7 weeks-ish, but anytime you try to go to 8, they recur with fluid. So we're anxious to try 8 milligram when it comes out in the United States. So here they get 8 milligram of aflibercept and they dry. They maintain on 8-week intervals. We go to 12, they don't show up, and they actually made it to 14. But this patient's a great responder who didn't respond to the other drugs we had, at least with extended dosing. Again, great case where 8 milligram of aflibercept is really helpful in getting this patient longer intervals with dry retinas. What about safety? Again, we see nothing that makes us think that 8 milligram has a more difficult systemic program. There's no hypertensive signal, there's no stroke, and no increase in inflammation. There have been no obliterative vasculitis like we've seen in many of the other humanized molecules. And again, this is a totally human product. Photon and pulsar. So in summary, we think we've shifted the curve of eligible patients so that more patients can go longer. You have less of those patients that have to come in all the time. And it's really great for the patients, it's great for the doctors, and it's great for the caregivers. Great animations here, by the way.
Thank you very much, Dave. Before you go back to that. So, Dave, if I said that Paulo is the early adopter, you are the early adopter in the US for everything, and maybe in the world. So what type of patients in your clinic, you showed excellent results in naive patients, you touched upon previously treated. We heard Paulo about the drying effect. What, in your clinical real life, Which group of patients do you recommend 8 milligram now?
Yeah, I don't see a reason not to use it in everybody. I mean, other than insurance issues in the United States where you have to step through different drugs or make people happy, there's no reason not to use the best drug we have in the cupboard. It's got a safety profile equal to the drug we've been using for 80 million doses worldwide. And it's a very comfortable transition. Certainly with newer drugs, after brolucizumab, we all kind of got burned, that 1 in 200. There's always a little trepidation. We are involved in most of the trials, so we usually jump in early. But I don't see any reason or any patient not to consider 8 milligram of aflibercept. It's a great drug, and patients love it.
Okay, and Paulo, you showed, Dave showed the naive patients. Are you, just in 1 or 2 sentences, because we're a bit delayed, is there a different way you converse with your treatment naive as compared to the previously treated patients when you recommend the 8 milligram?
Well, Anna, very schematically, dealing with a patient who's already been treated is usually easier because they do understand the burden of injection, so it's easy to transition them to a newer drug through which they will need less injections. With the naive patients, you have to go through the idea of being injected, what it is, what it means in terms of coming back for monitoring injections. But
yeah. Okay, great. So we heard what is already happening in the clinics and in the present, both in Europe and in the United States. And I would like to ask Professor Patricia Uduando to talk to us about how can aflibercept 8 milligram change the future practice.
The future or the present?
Both.
Let's see. Good. Well, my financial disclosures. So let's check how awake the audience is. So we've seen very interesting data, and probably to be practical, because we are very busy, we know how the clinics are busy, we need to put it into or translate it to daily practice. So does it really has an impact or a change or a difference compared to the past before we had 8 milligrams? So I want to know your opinion. Raise your hands. So what will be the biggest impact on your patient's care? Who is going for reducing the treatment burden? Raise your hands. Okay, good. Or simplifying the treatment practices? Who is going for this option? Okay, most of the audience is sleeping. Good. So, good. So let's see what it means. So we know that we have the basis for a treatment approval with the phase 3 studies for any treatment. But in the end, we really need to have something that change completely, if it's possible, the daily practice and the disease control. So seeing the results of the AMD patients, if we have 10 patients or every 10 patients with the result that we've seen, 8 of these 10 patients will have an injections every 12 weeks. And if we continue a little bit more, 6 of these 10 patients will have an injection and a treatment every 16 weeks. And finally, 4 of these 10 patients will have a treatment every 20 weeks. So it really makes a difference in terms of injections in the end, which is something that we can really measure. If we move to DME, to the photon result studies, we have a similar scenario, but even a little bit better, because 9 of these 10 patients, we have an interval of 12 weeks. 7 of 10 patients can be treated every 16 weeks. And 5, so half of the patients, can be controlled receiving an injection every 20 weeks. So it really makes an impact in many different aspects. Probably the most important, and we've been discussing about this, is the feeling of the patient. How do we translate it to the patient's feelings? So they can have more time to just relax with the families, more independence if they can maintain the vision better, improve quality of life. So we all know if we translate into daily routines, what can mean a difference in visual acuity, for example, the difference between driving or not driving, or reading or not reading. So this can really make a difference. To me, the most important, which is independency. My grandmom had wet AMD, and the worst for her was losing the near vision to read. But also the caregivers with direct or indirect aspects, because you see your family having some concerns or just maintaining their daily lives and independency, but also to be practical, to have fewer clinical attendancy, which is also important because they are usually workers. And finally, what about the clinics? So we are reducing the number of treatments. We know that the patients are maintaining the vision, and we have a reduction then in the cost, direct and indirect, so which is important. But to me, it's the first time that I'm considering to change the daily practice. So we are changing the clinics and the flow of the clinics to move into a more digital consultation, because I have two options. If the majority of the patients can be maintained in 12 weeks, and those really frequent flyers can be really maintained with 12 weeks, you can just go for a fixed dose, or you can try to extend it. The profile of the patient is so good that you can even try to extend to even 20 weeks. So it really makes a difference in the daily practice. And how may simplify this? So if we just compare the loading dose that we had at the beginning with 2 mg with 5 loading dose, now we have 3 loading doses in both diseases, which is much easier to simplify, to treat, or to try to treat very similarly the two diseases, and then try to extend, knowing that nearly half of the patients can be extended to 20 weeks in both diseases. And finally, which is also very important, we have the new prefilled syringe, which is completely different, very easy to use. You just have to push, twist, and inject. So it makes a difference also because we need to inject less. We have changed completely the syringe. We have changed the package, and it's also very important to be environmentally friendly. We also have a responsibility on that. So if we reduce the number of patients, considering the number of injections, and if we consider the number of visits and how it has changed completely the package, we are reducing by 35% the impact and reducing the CO2 equivalent emissions when we are treating patients on a very prevalent disease. So just to make a summary, we have now the option to have a 3 loading dose with both DME and AMD. We have the opportunity for the first time to try to extend till 20 weeks. That has been demonstrated in a clinical trial, and we have the new prefilled syringe. So now, have you changed your mind? Probably we don't need to choose. We really have an impact reducing the treatment burden and simplifying the treatment practices. Thank you very much. I stay. Good.
Yes, you showed us how it changes very significantly both your clinic and the world with reduced footprint and all that, all the long-term, all the long-duration drugs, and here with the PFS. Do you already use the PFS
Yes.
in your practice for the 8 milligram? Can you tell us about your experience?
Amazing. To be honest, it's precise. So when you have a very long list of injections to do, and it's already ready to use, that you don't really need to consider or to look what is the doses, because as you commented previously, sometimes we had the concern if we were really injecting the complete doses to a patient, and now you are sure what you are doing. So I think precision is very important, and this is to me the most reliable syringe.
Okay, great. Thank you very much. I understand that already this has a significant clinical impact in your practice, Patricia, as you've shown theoretically, but since you're already using both the 8 milligram and the prefilled syringe, then already you have a significant impact in your clinic.
Yeah, I think we are now analyzing the results because we need data to confirm what it's our feelings. But in both, in the pretreated subgroup of patients and in the naive patients, I feel very comfortable in extending the intervals because you know that the majority of the patients will be stable. So this is a very important point. So as David was showing, even those frequent flyer patients can be quite easily extended to 12 weeks. So you can just try to maintain it if you are more conservative or if you are busy. But if you can try to extend, you can also extend on a very easy way. So that's why we have changed a little bit the clinics and the flow and trying to just make the OCT every time the patient is coming for the injection and analyze it and then decide if the patient is extending or not. Previously, it was very difficult because we have to extend every 2 weeks and not more of the patients could be extended, so it really makes a difference.
And in the future?
Well, I think, as I said, that is not really future. We are all now trying to use it. So what I think is that the people that has not started with the treatment of 8 milligrams, as we were commented previously with the biosimilars, this is something different. So we should try to adapt this new therapy because it can really change in many aspects the disease control.
Okay, thank you very much. That was amazing. Okay, we have some time for panel discussion, and I understood everyone already mentioned it in some way, but I would like you to summarize what do you think it will do to the patients, to the burden of the patients themselves? Maybe start with you, David. You live in a pretty, I mean, your clinic is in the middle of nowhere, is it? So,
Yes, so
with all these horses and...
yeah. Many of our patients have a long drive, and it's quite the burden for the family, more than the patient. Patients sometimes love it. It's their one outing for the month or the 2 months. But the one that has to take off work and come, it's just fantastic. Anytime you can go from 8, 9 injections a year and get them even to 5 or 6, it's fantastic. And so it is a big step. The pre-filled syringe is great. And without the pre-filled syringe, it's often very difficult to get 70 microliters. And it takes you a few minutes to kind of get the hang of it, but it's really a great way to get the exact accurate dose. So I think that's just getting launched in the U.S., we think April 26th. So we're excited about that. Y'all have actually beat us to that.
And by the way, we've shown in previous trials, in a trial that we did, actually it was the MD thesis of my son, that when you draw from a vial, then it's really not accurate. It was published in Retina. Yeah.
You decrease endophthalmitis rates by half, looks like. You decrease inflammation rates, which are probably low-grade endophthalmitis. The pre-filled syringe is great.
Okay, Paulo, 8 milligram bilateral patients. Are you comfortable giving 8 milligram in same sitting in bilateral disease?
Well, not in the reimbursement scenario in Italy, we are not allowed to give bilateral same day. And to be honest, in my experience, either 8 milligram or other drugs or dosages, I quite rarely give bilateral injection, but that's my specific choice. And then the
it's
Italian
not your
scenario.
specific choice, it's because of the reimbursement issue, no?
Yeah, but even with the reimbursement, I might be out of the majority.
Okay, I'm sure David has a different answer.
Yep.
Yeah, so we get paid 50% of the injection fee for the second eye.
Oh, really?
So there's some docs that bring them back. I think it's crazy. Life's too short. I mean, my waiting room's fun and all that, but if I can get them less visits, I do almost all bilaterals. There's about 5% of patients that live alone and they don't really like the burning of the betadine or whatever, so they want to be in my waiting room twice as much, but 95% I do bilateral.
Patricia?
Well, in Spain, we are paid the same, so we really need to reduce the burden of treatment, so we do bilateral injections routinely.
Yeah, we just started with 8 milligram, but I do bilateral for any other indication, except pegcetacoplan that I do only one eye for if it's the first time. But other than that, I always do bilateral, and patients are very happy. Most of them can tolerate it pretty well, and if Israelis can tolerate it well...
I don't want to be the only one. Anybody else doesn't do bilateral same day?
Who is not doing bilaterals?
Same day.
Same day. Okay, you're not alone. Is everyone who is not Italian and not doing bilaterals?
Who's sleeping after the lunch?
Okay, I think that if the reimbursement scheme allows it, and even if not, like Dave says very gallantly, I think it might be helpful for the patients. Of course, you have to treat the other eye as a new patient and all that, like we're used to.
New patient.
Yeah, new set, new patient, and everything. Okay, now I have a pretty difficult question that I ask myself many times. Paulo, I'll start with you again, and then we'll go down the or up the panel.
No difficult question.
You have a patient who is really stable on 2 milligram. I, for example, I have a patient. She comes every 2 months to get the 2 milligram injection. Do you consider to switch her? And she's very stable. She's doing very well. By the way, she lives in Sardinia, and she tried to go from time to time to Francesco Boscia, but she can never find him. So you're here. So
he's traveling for meetings.
She flies specifically to Israel to get every 2 months. So would you and she's very stable. Would you consider switching her to 8 milligram?
Yeah, definitely. I think that's the ideal case to transition from these frequent injections with the 2 milligram to hopefully the less frequent with the higher dose. That's the typical case. Obviously, you want to talk with the patient, listen to her psychology, but I think this is the right choice.
Okay, I'll ask you, Dave, a more difficult question. Stable on 2 milligram every 3 months. You know, we have these patients. Are you switching?
Yeah, I think so. I think if you can get the, I'm worried about the diabetics because of compliance. The AMD, I'm not as worried about, right? They always come, but there's no reason not to. Those patients are doing well, and I would try to extend them further.
Okay, Patricia, when you decide to switch, what is your regimen? Are you loading? Does it depend on from what you switch? What is your treatment regimen?
Well, I think this is a very important question. So it depends on the starting point when you decide to switch. So we are trying to analyze exactly what it means. So if it's coming from a different agent, I think it's better to do the loading dose, because then the mechanism of action is completely different. So to
even
really
if it's 2 milligram?
No, a different molecule.
Yeah.
For example, faricimab or Lucentis or brolucizumab, I think you really need to do a loading dose to really have the effect of the new treatment. If I'm switching from 2 milligrams, it's a different story. So I do start from the interval where the patient is and try to extend.
So what do you mean try to extend? You give it, let's say you have a patient
If
in
the
2
patient
milligrams
is at
stable.
8 weeks, I then directly try to extend at 12 weeks, every time with this control of the OCT, and then we just check how the status of the patient is to decide if it's okay with that interval, or we have to reduce, or we can extend directly.
So you gave him every 2 months. Now you give him the 8 milligram, and you ask him to come after 3 months. Is that also your routine, Dave?
I usually go one time with their old interval. You know, I say, I want to see you back, and especially if they're switching from faricimab, and most of the time they're going to do better. It's a stronger drug, and I've never been impressed with the Ang2 component in their trials or clinically. But I'll go to, I'll do the same interval, but I'm pretty aggressive at extending after that.
So you'll do once the same
Right.
interval.
And
just to make
I don't
sure-
typically load. If they're there every 8 weeks, I'm not going to go to monthly load, because for one thing,
They will not want
They
it.
think you're crazy.
They will think you're crazy. Yeah. Yeah. Paulo?
I try to see what data comes from the trials. So I try to make it easy. 1, 2, 3 loading, if possible, and then I see the patient. I decide whether to extend to Q12 or Q16, depending on the pattern I see at the OCT. So no fluid, I may consider, depending on the patient, to go directly to Q16, if not Q12.
So if he has a little fluid when you switched him after 1 month, you would still extend him to Q12?
I go 1, 2, 3. So after the
What do you mean, 1, 2,
loading,
3? 3.
1, 2, 3 injection loading, and then I see the patient, the OCT. If no fluid is there, depending on the patient, I might consider to go directly to Q16.
No, but if there is a little fluid.
I might consider to go Q12 then.
Okay.
Paulo, do you do loading dose even when you are switching from 2 milligrams?
Pardon me?
Are you doing the loading dose even when you are switching from 2 milligrams? Because
The
it's
more
only-
I treat patients, the more I love the
Loading
loading.
dose.
I like what you said. If the patient is coming to something else, I
Yeah.
tend to give the loading. If coming from the 2 milligram, I may consider to give 1 injection only and then extend.
Yeah, but
That's good.
I think what you said is pretty right. If the patients are already getting every 2 months, they will think, he's giving me a new drug and now I have to
same.
come monthly. It's a little problematic in a way. Okay, and to the final question. We are always very happy if we have good efficacy and we have long duration. But I just want to make sure that all of you feel comfortable with the safety profile. In real life, in your clinics, in your experience, we've seen the very good safety. We know aflibercept for many years, and we know that the safety is very good in the trials. Is it also this way in your clinic? Did you encounter any significant side effects? Paulo, yes?
Well, this is a good question because we didn't touch an issue which may be important, it's not important. IOP, we are injecting 70 microliters, and we want to be sure that those patients do not develop IOP. So there are data coming from the photon and the pulsar. We did an analysis on our patients on IOP, different measurements, different time points, no signals. Although we have to know that for every single injection, independently from the agent, from the dosage, 50 microliters, 70 microliters, you have an immediate spike. We know that 1 minute after the injection, IOP goes up to 50, 60, 70, but then goes down regularly after a while. So no signals.
I know, Dave, that you're softening the eye always, right? Is that your routine?
Yeah.
Yeah, okay.
Yep.
Are you massaging or giving iopidine prior to injection? Dave?
Only, if patients have glaucoma, if they've got a 0.9 cup, if they gray out, I tap them ahead of time because it's just way quicker than massage or anything else. But it's really very few patients with 70
Usually
microliters over 50. It seems about the same.
Usually it's not yet. Okay, thank you very much. That was an excellent discussion. So you've shown that we have, with aflibercept 8 milligram, we have better, faster, and longer drying. We showed that it can be a very good first choice with eligible treatment-naive patients pending the reimbursement system. It has the potential for all of us to make a significant change in our practice, both by reducing the treatment burden and by using the very easy-to-use and very comfortable pre-filled syringe. Thank you very much. And please scan this QR code so that you can give us your opinion on how this symposium was held so we can do better in the future. Thank you very much for joining us today.